I promise not to cry today. I do thank Lisa and the board of directors and everyone both for the invitation to participate in the meeting and for the award. It really is truly remarkable. I am going to talk to you about this sudden cardiac death issue. And you've heard some things in multiple other talks today, and I want to kind of break it down into that practical application of these risk tools and how it makes a difference for each patient. Now, I don't have any disclosures of conflicts that are relevant to this talk or others. Because this talk has almost no levity in it whatsoever, since we're talking about death, I thought I would tell you that I've never had a conflict of interest, and I didn't quite understand how people got conflicted. So I went and searched on the internet, and here's what I found. It's a pretty good example of how conflicts might start. So a husband and a wife had an upcoming anniversary. And the wife started hinting to her husband what she might want for this special anniversary. And she said, you know, I want something shiny that goes from 0 to 150 in about 3 seconds. So think about that. She's wanting something pretty special. So her husband thought about that, and what he got her was a bathroom scale. And that's how conflicts start. Obviously, I didn't know anything about that, so anyhow. So we're going to talk about sudden cardiac death, and I'm going to, again, thank my colleagues. My colleagues share in this award. I mean, Joe gave me a nice talk here. Joe won the Laurie Award a few years ago, and the awards at Mayo are shared amongst the team because we are a tremendous team. And as I mentioned last night, it is the patients that allow us to do what we do. And so you've seen some numbers, but here are the numbers at Mayo. We see 5,000 patients with this disease. Our publications that stem from our patient work have been cited by over 6,000 other studies, and it's due to my colleagues' work, and I get to be lucky enough to work with them. And you've heard mentioned the 2011 guidelines, and I want to give my colleagues in the room who have been part of this, that have been pointed out in the previous slides, who are all here as part of Lisa's meeting. But I want to take a moment and be proud of my colleagues, because if you look at this list a different way, 4 of those names are from one place, and those are the colleagues I get to work with every day. And so I do consider myself lucky to work at this institution with these individuals, and lucky to get to work with all of you as patients and help take care of your conditions. These are my colleagues at Mayo Clinic that help take care of us. We have a big team, including colleagues at Mayo Clinic Arizona and Mayo Clinic Florida, who work with us very closely in helping manage patients that can't travel to the upper Midwest. Mike Ackerman is our genetics and pediatric cardiologist specialist. Dr. Durrani and Schaff are our surgeons. We have 2 genetic counselors that meet with all of our patients. And then Suzanne, who does all the scheduling for all this, including scheduling an operative date for you in case you want it at the same time you're there. And Caroline, our nurse, who takes care of all of our patients with us. So that's the team that allowed me the honor to be standing here last night and today with the award that's been presented to me. In terms of my talk now, I want to start with this patient. He's a 49-year-old man that I saw a couple years ago. He had been diagnosed in 1993 based on an abnormal electrocardiogram that led to imaging, and he got the diagnosis of hypertrophic cardiomyopathy. He didn't have any outflow tract obstruction. He was a very avid outdoorsman. He cross-country skied, he biked, he hiked. And when I took his history, he gave me 2 stories of syncope, which is the doctor's term for fainting. And he had an explanation for both of those. Both of those, he hadn't paid attention to his hydration. It was at the end of his exercise. So cross-country skiing at altitude, he said, I got kind of dizzy and almost passed out. And he was biking in 2007 with his wife and just said I was dehydrated, and once I got hydrated, I was fine. We talked about it in detail. He was completely asymptomatic otherwise. And so that was his history. His echo showed a heart muscle thickness of 21 millimeters. Remember, about 10 to 12 is normal for most adults. He had no outflow tract obstruction. And on his exercise test, 121% FAC means that he did 20% better than the average man his age in terms of performance on the exercise test. So he was fit. He could do anything he wanted to do physically. His blood pressure was normal. He didn't really have any arrhythmias of note. He needed to leave town. We recommended that he needed to have a Holter monitor to look for this non-sustained ventricular tachycardia, this heart rhythm we're worried about. We didn't change his medications because he was doing well. but we did recommend that he can be active but not participate in competition, and he had a tendency to want to get in bicycle races and those kind of things, and we counseled him against that. And he agreed that he wouldn't do those kind of things. But 3 months later, I got called by his wife. And he had gone hiking with some friends and jumped into a mountain lake after a long day's hike and didn't come out of the lake. This was a man with no risk factors for sudden cardiac death, unless we go back and review those fainting episodes again, but I don't have that ability anymore to actually ask him how dehydrated he really was that he got lightheaded. So this is the issue we're dealing with. This is a very sad situation. I think about this all the time, and this is why we struggle with this risk stratification. So how likely is sudden cardiac death in hypertrophic cardiomyopathy? Our colleagues in the UK, led by Bill McKenna and Perry Elliott, have said that the risk is about 7% at 5 years. 7% of HCM patients after 5 years will have experienced a sudden cardiac arrest. And on the left-hand side of this screen, you can see where that might compare to other diseases. So 7% at 5 years, if you did the math, that's about 1.2% per year. So 1.2% per year is between general population and high risk on this graph. And you can see patients that have had heart attacks are at 4% risk of having a sudden cardiac arrest in the next year. Patients that have heart failure with a heart muscle that's strength is reduced to half, their risk is up to 15%. So in the scheme of things, HCM patients aren't the highest risk patients, but it's way higher than the general population, it's almost non-existent in patients without heart disease. Doctors get really comfortable talking about these numbers and statistics. Too comfortable sometimes because we forget that sometimes our patients don't understand what morbidity and mortality and death rates and those kind of things mean. So to put this in context, there's 1,000 dots here representing 1,000 HCM patients. 7% at 5 years means that after 5 years, those 70 dots in the gray won't be with us. So that's the proportion of patients after 5 years, looking at all types of HCM patients who have experienced a sudden cardiac arrest and probably have died over the next 5 years. Now, I think it's important that we define what sudden death or sudden cardiac arrest means, because there are some issues, some kind of myths that come about. On the screen is kind of the definition we use when we do research studies, trying to look and see who's at risk or not. But the bottom line is sudden cardiac death means it happens to you without warning, and it's probably due to an abnormal heart rhythm. I get lots of patients who come and say, I'll worry about this once I start to get symptoms, or doctors who say, I'll do the risk stratification once they start slowing down. That's not what sudden means. Sudden means without warning. Sudden means we need to do it now so we can protect you, because for some patients, the first time they're diagnosed is when they're having their autopsy done. So sudden means we can't delay it. It is presumed, and most likely due to abnormal heart rhythms, that the heart tries to beat too fast and too chaotically, that it can't effectively pump blood, it doesn't supply your brain, and you can die. We don't have patients that we've been watching them with all of our fancy tools, echoes, MRIs, electrophysiology catheters, and then had them die while they're being studied. So we have to make a lot of suppositions about why this happens. And in HCM, there are a few things that you've heard about today and others that might set patients up for this. One of them is normally in a normal heart, the muscle cells kind of interdigitate like bricks on a building. They lay down neatly and they're all neatly organized. In HCM, they're kind of gnarled. They don't interact with each other, one another, and that sets them up for some of the scarring and fibrosis that you've heard about from Dr. Marin and others. The other thing is we know at the microscopic level, the blood supply to this thicker heart is not increased proportional to the thickness. And sometimes the smallest blood vessels are actually blocked. So that means the heart is living closer to oxygen debt than a normal thickness heart is. And when a heart starts to get an oxygen debt, it becomes more irritable electrically. And so that's one of the reasons why we think these hearts are more susceptible to going into abnormal heart rhythms. Now, you've heard about these risk factors. The ones in the blue boxes are the 5 ones that we paid the most attention to. And I want to talk about this slide for just a minute, because all of these things are risk factors, and you've heard that they're imperfect. So for instance, on the top right, mutations. There was a lot of work, about a decade ago, saying if you had specific mutations, that might be the key to identifying which of the patients have the highest risk form of HCM. Well, there have been other studies that have kind of contradicted that, saying that might not be true. But yet in the dark blue box, we know that people with a family history of sudden cardiac death are the ones that are higher risk. So the question there, it might not just be the single mutation that leaves that person at higher risk, but it might be something else, that mutation plus something else in their family that leaves them higher risk. So in summary, we still rely on a family history of sudden cardiac death. On the top left, non-sustained ventricular tachycardia. So ventricular tachycardia means the heart rhythm is originating in that patient, starting in the thick muscle, rather than in the internal pacemaker system of the heart, which starts in the thin-walled top chambers of the heart. When the signal originates in the bottom chamber, it easily gets distorted and bizarre and doesn't support normal contraction patterns. But we can detect that with the Holter monitors we set you up, the 24-hour ECGs where you walk around for a day. Non-sustained ventricular tachycardia means 3 or more abnormal beats in a row. So does 3 beats one time in 24 hours really, really increase someone's risk? It's a little hard to know. If they have a bunch of them that last for 5 to 10 beats, then we all get a little bit more nervous and shaky in the knees. As Marty pointed out, that may be due to the fibrosis or scarring that's inherent to the HCM, which may in turn may be related to how thick the heart muscle is. I mean, the more severe the expression of the disease is, the more likely you are to have all of these things. And it is hard to tease out which one of those things is more important. We may see a day when the MRI findings become an independent risk factors and are in their own blue box on this screen. But one of the issues, for instance, with the MRI imaging is determining when something turns from black or white means it goes through shades or gray. That means there's a computer algorithm that's designed to decide when is it gray enough to call it black. And there's no industry standard for those computer algorithms. So that's part of the issues for studies like we're waiting to see is can we come up with an industry standard that allows us to define black and white better to make these risk modifiers. As he pointed out, when you get to 20%, 1/5 of the whole ventricle being scar, that means the risk doubled. So that means it went from 1.2% to 2.4%. So at the end of the year, 2 out of 100 patients wouldn't be here. So it's not like the risk tremendously increases in an absolute number of patients, but it does so relatively increase the risk, and those are the intricacies that we have to consider in dealing with these. To give you a better idea about how these risk factors perform, if you just consider 1,000 patients with hypertrophic cardiomyopathy, the ones that are represented in orange are those who have wall thicknesses greater than 30 millimeters. It's less than 10% of our patients have that severe form. So how many of those are going to be dead after 5 years? It's the ones in pink. So it's a relatively high proportion of those patients with massive wall thickness who will experience fatal heart rhythms. At the same time, in the patients who don't have massive thickening, that many people will have died a sudden death. Because there's way more people who don't have massive thickness, it means even though the proportion is smaller, there's more absolute patients who will experience it. So that's why these risk factors don't work individually. The absence of a risk factor is somewhat reassuring, but it certainly is not perfect. And that's our problem. We don't have any great risk factors. As has been mentioned, we have no medications, no lifestyle therapies, no diets that will protect us or our patients from sudden cardiac death. So the only thing we have to offer is defibrillators. And they're not like parting your hair on the other side. There are complications that go with defibrillators, and we have to consider those. Barry Marin mentioned earlier today that strategies like this have been used to use those risk factors and decide who deserves defibrillators. The patients with 0 risk factors, we say reassure. Now, reassure doesn't mean guarantee, because like my patient I started with, 0 risk factors doesn't mean 0 risk. It just means lower than usual risk. And patients with no risk factors can still have bad things happen to them. And when you get patients like on the bottom 2 pink bars, people who have actually needed CPR, that seems pretty clear if they survive that maybe they ought to consider a defibrillator. And in between the 1 risk factor people, the 2 risk factor people, I say individualize is the right thing. I'm going to talk at the end about how this is always your decision as a patient. I've never told any patient they had to have a defibrillator. It's always their decision with me. So let's consider 3 of my patients, all of whom are still living, just so you know there's a happy outcome for each of these. This is a young woman who came to see me when she was in her mid-20s. She was a graduate student who, based on family screening, had been diagnosed on echocardiography with HCM. She was completely asymptomatic. She did have a family history of sudden cardiac death. Should we recommend a defibrillator for her? Just think for a moment about that. Another patient is a 19-year-old man with non-obstructive HCM with some shortness of breath. But on his 24-hour Holter monitor, he had 2 5-beat runs of non-sustained ventricular tachycardia, but no other risk factors. So that counts as 1 risk factor in our scheme. Or my third patient is a 47-year-old lawyer, and Cynthia will tell us that lawyers we have to pay special attention to. He has class 3 dyspnea, shortness of breath. He had outflow tract obstruction at rest. He had not only non-sustained VT, but his blood pressure went down when he walked on the treadmill. That's not normal. Your blood pressure is supposed to go up. And a dropping blood pressure with exercise is one of the things that's been identified in the past. So if we consider those 3 patients, you would say the first 2 have 1 risk factor and we should individualize them. And the third guy has 2 risk factors and maybe we should just go ahead and give him a defibrillator. And my response to that is sometimes counting isn't so easy. How isn't it easy to distinguish 0, 1, and 2 from each other? Well, I'll show you. So the 20-year-old graduate student with a family history of sudden cardiac death, her family history is this. She has 11 family members with hypertrophic cardiomyopathy. 10 of those had either had their defibrillator go off or they had died. So does that still count as 1 risk factor or not? The 19-year-old man, he had the 2 runs of non-sustained ventricular tachycardia. On echo and on MRI, his heart is 29 millimeters thick. Now the risk factor is at 30. What I want to tell you is that the risk doesn't stay low at 29 and then jump up at 30. The risk increases with each millimeter of thickness. And so for this individual, it gets higher and higher. And in fact, if you look at all the patients with 30 millimeters of thickness, the highest risk group is 30 millimeters of thickness under 30 years of age. They have the highest risk. And I guarantee you, if we brought Marty back in here, he would not swear that 29 is different than 30 on an MRI, and I certainly wouldn't do it on echo, and I don't think Harry would do it on an echo either. 29 is not different than 30 on the tests we have. They're not that precise. They're not that accurate. So is this still just 1 risk factor for this man? This is the discussion I need to have with him to help him make a decision about whether he thinks a defibrillator is right for him. Our lawyer friend, we're not going to put in a defibrillator just because he's a lawyer, even though it seems like it protects us a little bit. Maybe we'd make it shock him more often. I don't know. Yeah. So he had significant symptoms despite medications, and we're going to offer him myectomy. Does that change it? Well, Joe just showed you some slides that said maybe it does. Remember, after myectomy, our patients have a very low sudden cardiac death rate and very low rate of defibrillator discharges. So did we take him from 2 risk factors down to 1 or less? We don't know. Certainly it still happens, so we can't say myectomy eliminates sudden cardiac death risk. That would be wrong. That would be overstating it. But certainly the evidence would say it decreases it perhaps. And that patient and that family needs to consider it in their own context. So you've heard a lot about counting risk factors, and when the guidelines committee got together, we tried to do a little bit of nuancing of that to give people some ideas about how to use these risk factors. And so if someone has had a cardiac arrest, they've collapsed, they've required to be defibrillated, they've had CPR, or if they've had rhythms that didn't terminate on their own, we have said that that's usually the group that you recommend a defibrillator to. If they have a family history of sudden cardiac death, if their heart is massively thick, or if they've had recent scary fainting episodes. This isn't scary that you fainted when you first stood up, or that you fainted at the sight of blood, because we can explain those things. It's you were talking to your friend and you fell over in your food. That kind of scary. In those patients, it's quite reasonable to suggest a defibrillator. For the people that have the non-sustained ventricular tachycardia or abnormal blood pressure response to exercise, that's what we talked about. Let's look at other things, like the scarring on the MRI. Do they have aneurysms? Is their wall thickness 28 or 29 and not yet 30? Do they have certain genetic mutations? If they have those other things in the presence of these two, then it also is quite reasonable to consider a defibrillator. If it's just one of those two things in isolation, it makes us a little uncertain as a blanket rule about whether every patient like that would really benefit from a defibrillator. And certainly if they have none of those risk factors, we think that patients probably should stay away from defibrillators. So that's kind of the way the guidelines committee did it. It tried to give some more nuances and some more weight to some of these risk factors because they're not all equal. Now the important thing is that the discussion isn't done yet with the patients. This risk factor discussion is like the opening line, but it doesn't close the deal. We're not done talking about this yet. We need to talk about what the benefits of a defibrillator are and what the non-benefits are. So obviously, the biggest benefit is it saves lives. There's no questioning that. Defibrillators help people live that otherwise wouldn't have. It also can relieve a tremendous amount of anxiety for a patient and family to know that they have that safety net. And that is a huge benefit to many people. And there are people that are technophiles who they hear about defibrillators and they kind of like the fact that they've got this thing and they can read about it on the company website and they can have their uplink and their data's going back and forth. And some people really like that kind of stuff. But there's also a list of things that can go wrong. And we need to talk about that with each patient. So it takes a minor surgical procedure to put these things in. And as someone said earlier, things happen. You can damage the lung underneath where the defibrillator goes. You can damage the blood vessel. You can push a lead through the heart, in theory, if you push hard enough. So procedural complications can occur. The devices can deliver what we call inappropriate discharges. An inappropriate discharge is when the device shocks somebody, and then we go back and we look at the software, and we find out there wasn't actually a fatal heart rhythm going on at the time. Why does that happen? It happens because the device is being too cautious. So something was going on with that patient at the time. The device wasn't sure what it was, and its default mode is, if I don't know what it is, I'm going to fix it. And so it'll deliver energy, and that's being overly cautious, and we can look at the circumstances and reprogram the defibrillators at that point. But we deem those inappropriate discharges. Devices can malfunction, as Dr. Marin talked about earlier today. Now, I put on here the downsides of the defibrillator, that it eliminates sudden cardiac death as a potential mode of death. Why would that be a downside? Patients that have dilated cardiomyopathy, very low ejection fractions, qualify for defibrillators just because they have a low ejection fraction. But if we take away sudden cardiac death as a mode of death for them, that means they're going to die a heart failure death, a death of shortness of breath and persistent fatigue and drowning in their own fluids. And some patients don't want that. They want this as a possibility. They want the possibility to die peacefully in their sleep. And that's an individual decision for an individual patient that I can't nuance. It's their decision. Having a defibrillator in some people actually increases their anxiety because they sit around and wait for something to happen. It's happened. We've had patients asked to have them turned off or taken out because they were afraid something was going to happen. They just couldn't get their mind off of this thing sitting in their chest. And as was talked about earlier, there can be employment issues if you get a defibrillator. That shouldn't be the reason why you decide to get one or not, but it's something that needs to be considered for individual patients. How frequently do these things occur? On this graph, appropriate discharges, so this is from Dr. Marin's registry, at about 4 years, 1 in 5 patients in that study had gotten an appropriate shock from their device. 1 in 4 had gotten an inappropriate shock. 5% of the patients had something go wrong with the lead. That's the wire that connects the energy source to the heart. Either that lead had broken, or the insulation around the lead had broken, or it had become detached from the heart muscle to a spot where it wouldn't be effective, or the manufacturer discovered they had a defect in their manufacturing and they had to recall it. So 5% of patients. If patients get infections in their bloodstream and you have artificial material in the bloodstream, like a device lead, the bacteria can set up on that device lead and become a persistent infection that can only be cured if we take that lead out. That's another minor surgical procedure, and then another decision about to reimplant, and another minor surgical procedure if we do. So infections are not minor issues. And occasionally you can get bleeding or clotting problems around these leads taking up space in veins. I don't want to overemphasize these downsides, but they're real and they shouldn't be glossed over either for individual patients. And so for me, the way I leave it with my patients is that I help them identify the risk factors and try to put their individual risk in scope. And my job is to help them decide whether they think a defibrillator is appropriate for them. And the bottom line is, if they leave my office and they're afraid to do things that make them who they are, that bring joy to their lives, because they're afraid they might die suddenly, then they should consider getting a defibrillator. But if they don't have that risk, or if they think the defibrillator is going to increase their anxiety, then maybe they should stay away from it. And that's why it always comes down to the patient's decision. It incorporates their personal values, their faith, their understanding of what we talk about to make a decision for themselves. Thank you very much.
And we are very lucky to have them come down and share their experience with us. And Dr. Rakowski is going to talk to us about a predictive model for gene identification. So we're going to head back into the genetic realm. And without further ado, Dr. Rakowski.
Lisa, thank you very much. This may be my first visit here, but it's a very impressive visit. And I just wanted to compliment you all on what you've done, how spectacular it is. I think you probably get used to it, but it really is a remarkable achievement as to how a grassroots organization can really alter how clinical practice is performed and the wonderful things that you do. You mentioned Doug Weigel, and I come from Toronto, and really Doug Weigel put Toronto on the map in terms of hypertrophic cardiomyopathy, and I'm honored to be the Doug Weigel HCM Research Chair and run the clinic in Toronto. Along with the Mayo Clinic and the Cleveland Clinic, we're probably the third largest in terms of volume in North America. We see about 2,500 patients. We have patients referred from all over the country as well as internationally. And I think that for all groups that are experts in hypertrophic cardiomyopathy, the message that you've heard is that it's a collaboration. And ours is the same way. It's a collaboration of clinical cardiologists, electrophysiologists, surgeons, basic scientists, interventional cardiologists, human geneticists, and genetic counselors. And our goals are to risk stratify patients for sudden death. You heard a lovely presentation by Steve Ommen on that. We do genetic assessment and counseling on every new patient that comes. And one of the nice things in Canada with the unified universal healthcare system is that governments can decide what to fund and what not to fund. And genetic testing in the province that I'm from in Ontario is funded 100% by the ministry with no copay. We manage patients' symptoms, particularly outflow tract obstruction and arrhythmias. Now, we got involved in being interested in genetic testing 25 years ago. The beta-myosin heavy chain gene was sequenced in Toronto by C.C. Liu. And we thought in those days, very foolishly, that, boy, if we only knew what the genetic mutations were that caused this disease, we would understand everything about the disease. Wrong. What we did find out was that this was a challenging endeavor, and that mutations and their discovery is one part of the disease. And Cricket gave you a very nice overview of the genetics of hypertrophic cardiomyopathy. But it's important to remember that the genetic diagnosis is only step one, and it's not possible to do in every patient. So the major role of genetic testing is to discover mutations that cause disease, the early identification of hypertrophic cardiomyopathy, the identification of high-risk groups, as you've heard before, is really not something that we do very effectively with genetic testing. There are really only a small number of mutations that have likely been shown to be related. And a lot of the confusion came because early on, if you test people who have familial sudden death and you find a mutation and you say, wow, here it is, we found a mutation that causes sudden death, but the reality is that you've been biased by the groups that you studied. When you do genetic testing, it's important to link it to a genetic counselor who will help provide the counseling that's required, disclosure information, to understand the accuracy of results and what is a true disease-causing mutation from a variant of unknown significance, and confidentiality. Our consent form for genetic testing is more extensive than the consent form if you needed brain surgery. Ultimately, the goal isn't going to be to just say you have the disease, but it's going to say why did you express the disease in a particular way, which conventional genetic testing doesn't do, and to use genomics and proteomics technology, that is genes and the proteins that are created in the abnormal proteins and those that are upregulated to cause excessive growth and scarring, to recognize them, to understand them, and to modify them. Well, you heard that a number of us were involved in the guideline document that was published in December 2011. And the guidelines on genetic testing, Cricket and I were the ones who helped start writing that section that were then vetted by the rest of the group. And I'll just summarize some of the guidelines that came out of it. So one is that genetic testing is reasonable in the index patient, that is the first patient seen, to facilitate the identification of first-degree family members at risk of developing HCM. Genetic testing for HCM and other genetic causes of unexplained cardiac hypertrophy is recommended in patients with an atypical presentation of HCM or when another genetic condition is suspected to be the cause. So that is if you don't really know if they have HCM or if you suspect a copy, a disease that mimics but isn't really HCM, you heard some of that earlier, or in screening patients where there's a known familial mutation that is disease-causing. You can then screen other family members for that specific mutation to say, yes, you do, or no, you don't have hypertrophic cardiomyopathy. So why offer genetic testing? Well, let's say this gentleman here comes to see a cardiologist, is found to have hypertrophic cardiomyopathy. This is the rest of his immediate family. Who else in this family does and doesn't have HCM? Not just from a clinical perspective. You may test some of these people and they're clinically normal, but do they carry a gene that will likely make them develop HCM? And you heard that this is an autosomal dominant form of inheritance. So you only need one copy from one parent to have HCM. So here in this family, this is the index patient that came. Who else in the family has the disease? Well, there was a mutation that was identified in this patient in green, and the other family members who were found to carry that abnormal gene were his mother, his sister, and his daughter. And everybody else in this family did not carry the gene, and so they don't require ongoing clinical testing because they're genetically negative, they're not going to develop the disease, whereas those who carry the gene either have the disease or are likely to develop it. There's some challenges in that genetic testing. So here is another family where the index patient was a 26-year-old woman whose first manifestation was sudden death. So as a result of that episode of sudden death, everybody else in the family is screened. There's a mutation that's identified. 3 of her sisters are shown to have hypertrophic cardiomyopathy, who both carry the gene and have expressed it clinically. And for a variety of reasons, they get a defibrillator, some of which have had appropriate discharges. But there's a 37-year-old who is a cousin who carries the gene but hasn't expressed it yet in this high-risk family. And there's an 18-year-old daughter who has the gene and hasn't expressed it. So we knew what to do with these patients. What do we do with these patients? And we don't really know the full answer to that yet. So just because we know they carry the gene doesn't always help us in terms of the decision-making that's required for management. So is it important to find a gene in patients, and does it tell us that they're at higher risk? Well, there's some studies that suggest that those people who carry a gene for hypertrophic cardiomyopathy do have higher risk. So you can see in the solid bar, those who don't carry a myofilament mutation had a better outcome in terms of the percentage who died, had an ischemic stroke or progression to bad symptoms than those. Here you can see those who carried a myofilament gene had a worse outcome than those who didn't. And when it was subdivided into a number of categories, including whether they were going to likely have heart failure or high filling pressures, in all of these, people who carried a mutation were worse. And in fact, if you had 2 mutations, as about 3% of the hypertrophic population do, the more mutations you had, it was likely that you even had worse disease. So does that really mean that those patients are worse off if they carry a mutation? Well, some of it may just be how we select the patients. So some phenotype negative patients don't really have genetic HCM. They may have hypertension that gives them a little septal hypertrophy. You've heard that you can get outflow tract obstruction without really having hypertrophic disease. And so you may have that group of patients included, and they have a better prognosis anyway. There's also tremendous phenotypic heterogeneity for a given genotype, and we'll talk about that later in a minute. And then those patients who have the apical variant, that's about 7% of the hypertrophic population, where the disease is primarily in the apex alone or in the midventricle in the apex. We've shown that they have a longevity that is similar to an age and gender matched population. Well, Marty Maron showed you this slide of the phenotypic variability of hypertrophy on MRI. So a patient who you can have, let's say there are 6 different patients that we have here. Each of these patients can have the same mutation and express the disease in tremendously different ways. So how important then is just knowing the mutation? That isn't the key thing. It's helpful. It's helpful in saying you do or don't have hypertrophic cardiomyopathy, but there are a whole bunch of other modifying factors, things that regulate muscle growth and scarring, that tell you, are you going to have a big septum here, just a little bulge here, hypertrophy at the tip of the heart, this big mass here, hypertrophy in a funny place. So there's so much still that we don't understand about this condition. Can we identify at-risk family members? Well, our detection rate is only about 40%. Not all gene variants are associated with disease, so there are some people who have reported mutations and erroneously told patients they have a disease-causing mutation only to find out that it's not really a disease-causing mutation. It doesn't track with disease. Some families have multiple mutations, and you may only discover one, and it may be a second one that you haven't discovered that doesn't allow you to fully exclude disease in some people. We know it's not that good in predicting sudden death, and it's limited value in prognosis. So with those caveats, so just knowing the mutation isn't everything. It's still useful, and it's useful to try and predict who is going to likely benefit from genetic testing given its expense and incomplete availability, particularly in the United States. So Cricket Seidman and others have been key leaders in telling us which genes and which sarcomeric proteins are affected. And here you can see in yellow the 8 genes that are most commonly affected, with myosin heavy chain and myosin binding protein C as the 2 most common ones, and then the troponin mutations accounting for about 10% of those with positive genotype. When you do genetic testing on 100 people, what percentage are going to be genotype positive? Well, that really varies by which study you read, which country it was done in, and most importantly, which population of patients they studied. So here we have 2 Italian populations, and in one study, it was only 24% detection rate, in another study, 62%. Granted, this study only looked at the 2 most prevalent myofilaments, but nevertheless, a 2.5-time difference. A French study looking at 9 myofilaments, 63%. 2 American studies, a little over a third. Our large cohort, a little over a third. And some of this then depends on the nature of the patients that you study, how old they are, do they have a family history of hypertrophic cardiomyopathy. Now, even though the guideline document suggests that genetic testing is reasonable in every new patient that you see to try and detect disease in other family members, why isn't it routinely performed? We formed a consortium of over 30 hypertrophic centers around the world, and many of them only screen a very limited number of patients with genetic testing. So why? Well, part of it is the cost for doing this for the full panel is about $2,500. For some of you, it's covered by insurance. For those patients in the room, just raise your hand if you don't mind identifying that you're a patient with HCM. And now show how many of you have had genetic testing. So maybe half, and probably this is a group that's pretty motivated to have it, so maybe a little more than half. But I'm sure that it's far less than half of patients with hypertrophic cardiomyopathy who really have had genetic testing. And so I think a significant factor is, can you afford to pay for it if your insurance doesn't pay for it? Again, it's effective for disease diagnosis, but not so much for its management. There's implications for insurability, so if you're clinically negative, you can get insurance probably, but once you are genetically positive, if you have to disclose that, you probably can't get insurance. And then there's this general anxiety about genetics and genetic testing, and it scares some people that somebody's going to know about your genes. So what we did is, because we can genotype our patients, and for about the last 4 or 5 years, we've been able to do it on all patients and have the government pay for it. We looked at a consecutive group of about 500 patients. Most of them were done in about 2007 to 2010. And we said, all right, let's see if we can predict which patient is likely going to be genotype positive. And that may be helpful in saying, all right, you either are unlikely to have a gene that's detected or you're very likely, and that may influence some payers or it may influence some patients to decide about having it. We did what was called a logistic regression for a positive phenotype. So what we did was we looked at individual risks. We put them through some fancy computer modeling to try and create a score. In our 471 patients, we had over 500, but we excluded those in whom we couldn't get complete clinical follow-up. And our detection rate was about 35%. And from this, we constructed our risk score. If we looked at the kind of mutations that we found, they were very similar to what Dr. Seidman reported, roughly 40% myosin-binding protein C and a similar number of myosin heavy chain, and about 7% or 10%, 9% troponin mutations. So those are the 3 most prevalent ones, and that was the breakdown that we found. So these are fairly representative patients. When we looked at the kinds of predictors of who was likely going to have a positive genotype, we thought of what was published in the literature in studies that didn't look at them all together. And we looked at things like age of onset, the pattern of hypertrophy, whether there was a family history, is there arterial hypertension, are you male or female, how thick was your heart muscle. And each of these, in a multivariable analysis, were predictors of whether you're going to have a positive genotype. Some were predictors of yes, you were going to, and some were predictors of no, you were less likely to have a positive genotype. And so we could calculate an odds ratio and a p-value for them. And then what statisticians do in computer modeling is to say, we're going to assign a weight, a relative weight to each of these, and then create a score, and then each patient can have an identified score that will then say, this is your precise percentage likelihood that we're going to be able to identify a gene in you. So for age of diagnosis, our score ranged from -1 to -7, hypertension -4. That is, as you got older, the negatives mean we're not likely going to find it in you. The positives are we're more likely going to find it in you. So the older you are, the less likely. If you have high blood pressure, we're less likely to. The thicker your wall muscle, the more likely we are. If you're female, and we don't quite understand completely why there are these gender differences, but if you're female, we're more likely going to find it. If you have a certain kind of morphology to your heart muscle thickening, we will, and certainly if you have a positive family history, we will. Now, if you look at age, this is a study that Dr. Seidman's group did. You look at the sarcomere mutations that they identified, and it's like in our group, roughly 40%, 35 to 40% myosin-binding protein C, heavy chain, the same number, and troponin, about, again, 10%. If you look at those where there's a family history, the detection rate was 60% out of 551 probands, that is, initial patients screened. But if you had elderly onset hypertrophic cardiomyopathy, then it was mainly myosin-binding protein C, very little myosin heavy chain, but the detection rate was only 16%. So the older you are, the less likely. Either it's because we just haven't discovered those genes, or some of those patients have developed something that mimics genetic hypertrophic cardiomyopathy because of hypertension, because age-related changes to the septum. Dr. Lever has been key in helping us to understand that age is an important issue. And here in our own study, here is a plot of your age by initially 0 to 25, and then every 10-year segmentation after that. And you can see as you get older, it's less likely that we're going to find a genetic mutation, going from if you're under 25 to over 70%, to if you're 56 plus, it being about 20%. So we assigned a weight to that. So again, the minuses are that you're less likely going to have a genetic mutation discovered by conventional testing, younger that you are more likely to have it. And then we, as I said, gave weights to those other factors. And why should we do this? So we should do it because there is a cost-effectiveness issue with genetic testing. As you heard earlier, if you are genonegative and there's a known family mutation that you don't carry, you don't have to have an echo and an MRI and a clinical assessment, all of which generate costs. So there is a cost saving, but that cost saving is going to be maximized if we know who we should do genetic testing in. So negatives, and this testing cost will decreases as time goes on and technology improves, but for the time being, it's an important issue. We also learned from the Mayo Clinic that there are different patterns of hypertrophy based on where the muscle is thick. So if the muscle is thick in the basal part, that is the upper part of the septum, only roughly 10% of those patients had genopositivity, even though in their series it was more than 40% of the patients. If you looked at apical HCM, only 10% of patients had apical HCM, and they had a 30% genopositivity. We published a paper earlier this year where it was only 11% in the largest reported series of gene testing in apical hypertrophy. And if you had this pattern or this pattern, you had a much higher likelihood of genopositivity. Well, in our cohort, we looked at those patterns of hypertrophy, and we lumped these two together, saying if you had this what's called reverse curvature, where it bulges into the septum and into the septum bulges into the LV and RV, or if it's neutral, that is, it's thick, but thick most of the way down, that means you're more likely to be genopositive than these two groups if you just have this bulge at the upper part, the sigmoid septum, or if it's mainly apical, you're less likely to. So we categorize people into the category 1 or category 2, with this being the more likely to find a gene, the less likely to find a gene. So when we put it all together, we looked at these variables, we plotted them, and we also looked at tertiles. That is, we divided people into low, intermediate, and high likelihood of us being able to tell that you were going to have a positive genotype. The score of -9 to -1 was, your probability was 11%. If your score was 0 to 6, your probability was 30%. If your score was 7 to 19, your probability was 66%. And then we also looked at the short model, the simple model. If you only looked at family history and septal morphology, how good was that compared to the more extensive model? So this is a graph that shows you what would have been predicted by the model and what we observed. So predicted is these black dots, and observed are these bars. And this is the probability of detecting a mutation on genetic testing. So you can see if your score was 15, you had about a 90% chance of us detecting a mutation. If your score was -6, the likelihood was 5% that we were going to detect a mutation. So by being able to tell a patient, this is your score, we can take this model and say, okay, here's your pretty precise prediction of how likely you're going to have a mutation. And maybe you're not going to want to spend $2,500 if there's only a 5% risk, but if there's a 90% risk, boy, you really want to know, because it's going to be very helpful to identify those family members at risk. So we also looked at it in terms of these tertiles, that is low, medium, and high risk. This is the number of patients in each of these categories. Again, we looked at observed versus predicted. There was a very tight correlation between that. And so again, that's sort of a simple way of saying you're low, medium, or high risk, although the precise score is a little better. But if you only looked at two variables, it wasn't bad. If you just looked at the morphology of the septum, as well as whether there was a positive family history, it was reasonable. But the difference was, so both were good predictors, but the more extensive model, there were 41 patients where they would have been incorrectly classified as intermediate instead of high risk, and another 4% who would have been classified as low risk rather than intermediate. So the more complete analysis is better, although the quick and dirty is also a reasonable way of telling you roughly whether you're low, medium, or high in terms of its development. So that's the model we developed. We think that it has clinical and practical utility for a lot of patients who aren't necessarily going to get it routinely and who need to think about it. We hope that it'll influence payers to pay for more of this. But the real hope in the future is that this understanding both of genes and proteins is going to be cheaper. Cricket talked to you about machines that can do this now for $1,000 and look at your whole genetic code to do that. We think that that is going to be the future of testing, and that it will also identify abnormal proteins. And it's the proteins and the interplay that they have with genetics and how they drive how much scarring and how much thickening you have that is the key element that's missing, that needs to be discovered in the next number of years so we can then tailor therapy. This is reversing abnormal development. There are a number of multi-center trials looking at patients who have the gene, who haven't expressed it yet, and trying to prevent hypertrophy and scarring with various drugs. The hope is that both the genotype definition and the protein abnormalities that are discovered will lead us to hopefully what will be to prevent or greatly limit the ravaging effects of this disease. Thank you very much for your attention.